Alright, this is brief second generation antipsychotic overview part 3. Let's look at Abilify or aripiprazole next. It's a quinolone derivative like brexpiprazole or Rexulti. Although Abilify, Rexulti, and Vraylar are antipsychotics that block dopamine receptors, they all actually partially agonize dopamine receptors. I don't think we're completely sure what that does with its mechanism, but we suspect it might decrease motor side effects. It might also give it some boosted antidepressant activities. A common side effect of all three of these is akathisia. This is internal restlessness. You might feel intense, uncontrollable need to move, or an inability to physically sit still. These generally have a lower propensity of weight gain as opposed to like Zyprexa, Seroquel, and Clozaril. This is the side effect profile for Abilify. Here we see weight gain and headache and agitation and akathisia. Here's the little map for Rexulti, very similar to Abilify. Rexulti and Abilify are sometimes used at low doses as adjunct therapy in depression or add-on therapy. Keep in mind the side effect profile when we're using antipsychotics for depression outside of psychotic diagnoses. While Rexulti and Abilify have partial agonism on the D2 receptor, Vraylar has partial agonism on the D2 and D3 receptor. I don't believe we have clinical significance for this yet. I forgot to mention, but Rexulti, Abilify, and Vraylar all have partial agonism on the serotonin 1A receptor. This is the receptor that Buspar acts on. This is also the receptor that flibanserin or Addy works on. Rexulti has a slightly better side effect profile versus Abilify. Vraylar has good brain penetration and is said to enhance cognitive functioning. It also has active metabolites. Its half-life is 2 to 4 days, and one of its active metabolites has a half-life of 1 to 3 weeks. This long half-life is good because if a patient forgets to take a dose, they still have pretty much adequate level of plasma concentration. This is its side effect profile if you're interested. Here we have 20 to 21% akathisia, as well as some Parkinsonism. I don't know if I mentioned this, but this happens when you block dopamine receptors. Next, we're going to look at Latuda, lorazepam. You have to take this with at least 350 calories to get adequate absorption. It's a CYP3A4 substrate and a partial serotonin 1A agonist. This is its side effect profile. Remember, it doesn't cause any weight gain. It's in the same drug class as Ziprasidone or Geodon. Ziprasidone needs to be taken with at least 500 calories. It has a shorter half-life than Latuda, 7 hours versus 18 hours. So it needs to be taken twice a day versus daily, which is Latuda. Warning with Ziprasidone is QTC prolongation. Of course, be careful with patients with long QT syndrome and electrolyte abnormalities. Another drug that doesn't cause weight gain is Lumateperone or Caplyta. It's a tetracyclic butyraphenone derivative. I actually did a presentation in school in 2020 about this drug. It's pretty sedating. It modulates glutamate. Along with the dopamine hypothesis of dopamine excess causing schizophrenia, there's a glutamate hypothesis of deficiency of glutamate causing schizophrenia or a dysfunction with glutamate receptors. I'll mention that drugs that block NMDA receptors like PCP and ketamine can cause schizophrenia like symptoms in people. And then of course drugs that act on dopamine like loripenerol and cocaine and methamphetamine can also cause those symptoms. Hallucinations, psychosis, etc. Caplyta does not bind to histamine receptors or muscarinic receptors, and it does have some moderate serotonin reuptake inhibition activity. I always forget Iloperidone or Fanapt exists. It's also a benzoisoxazole derivative like risperidone and paliperidone. Something to point out with Iloperidone is that it has a risk for QTC prolongation. Iloperidone and Ziprasidone have the highest risk of the second generation antipsychotics. It has pretty high binding affinity to alpha-1. That's why its most common side effect is dizziness. It's because of this orthostasis. Just like the other dones, it can also cause some hyperprolactinemia. It's a 2D6 and 3A4 substrate. It has a pretty hefty titration. Look at that. 1 twice a day, 2 twice a day, 4 twice a day, 6 twice a day, 8 twice a day. What the hell? This is again because of its orthostatic hypotension. If you miss like more than 3 days of treatment, I would recommend restarting that titration. Fanapt is not recommended in hepatic impairment. I also don't see acenapine or Saphris that often. It has pretty hefty affinity for a lot of receptors. I didn't mention this earlier, but we call drugs like this dirty drugs. Dirty drugs act on a crap ton of different receptors. Saphris has pretty terrible oral bioavailability. Sublingually, it's a little better. That means it goes under the tongue and absorbs like through that mucosa. Something interesting with acenapine is it can cause dysgeusia, which is like a distortion in taste, as well as hypoesthesia or numbness of the mouth when taken sublingually. This is like for like an hour. But this is a side effect profile if you're interested. Sedating, dizziness, headache. This is a complete chart. If you want to screenshot it, it compares the different antipsychotics and different side effects. And then this is another little chart up here that's kind of interesting. Shows the different side effects associated with different receptor activity. And bonus, I guess I'll mention is Xanomeline. This is a cholinergic agonist. It's not an antipsychotic. It doesn't block dopamine receptors. It was just FDA approved in September of 2024 with trospium. It is called Cobenfy. Trospium is a peripherally acting muscarinic antagonist or blocker. It's to mitigate the side effects associated with this muscarinic activity. I'm interested in to see how this is going to work with post-marketing surveillance. But yeah, there's a balance in the brain with acetylcholine and dopamine. They're like inversely related. The brain and all that nitty-gritty is a little bit outside of my understanding, but this activation on acetylcholine receptors seems to decrease dopaminergic activity in the brain. We see the opposite when we use drugs like benztropine or anticholinergic medications for EPS. They block those receptors and increase the dopamine a little bit. Xanomeline is also said to increase dopamine in the prefrontal cortex, which helps with negative symptoms of schizophrenia and then cognition as well.